Hello.
Good morning.
Good. It's actually almost morning my time. It'll be midnight in 24 minutes.
Okay, it is 4:30 in the morning, so it is very morning on my side.
Where are you located at?
In Italy.
In Italy. Where in Italy?
North, very close to the Switzerland. Say almost 1 feet in Switzerland and 1 in Italy.
Oh, okay. Yeah, I'm in the US in Pennsylvania, Pittsburgh.
Okay.
Yeah.
So really spread around the world.
Yes. You are trying to wake up in the morning and I'm trying to go to sleep.
Yeah. Not the best time for anyone.
That is true. Yeah, my name is Saiful Haq. I can see your name. And how do you pronounce your name?
Antonella Fogliata. It's not an easy name, I know.
And Antonella Fogliata. Okay. Look, I'll try. Yeah.
Nice to meet you.
Nice to meet you.
Your name is preceding you. See, it is. See, your name is known, definitely.
Oh, boy, thank you. No, I believe I've seen your name also. Yeah, I come to Italy quite a few times actually. Pre-COVID time, I used to go to Italy about 3 or 4 times in Rome.
Yeah.
A
Wow.
year. Yeah, because
Rome
we have a cancer center there. Yeah, we have a cancer center there. In our organization have actually 2 cancer centers, one in Rome, San Pietro, and one in Mirabella. It's about 2 hours north.
Yeah, yes, the Pennsylvania, yes. San Pietro Fedele e Fratelli, they are
right. That's my PMC. That's my center. Yeah. Yeah. So
I'm doing something with the San Pietro. We are doing some nice work together with the San Pietro people. It is nice group. I know Randa El Gavari.
Okay, yeah. So you're working on that.
Yeah, we are doing some nice things on the
MR-Linac.
Yeah, yeah. On this, I would say nice and funny profiles. They are. So it is nice. It is a work we are doing together with other 2 Italian centers, one in Sardinia, and another one, the Policlinico Gemelli in Rome, on these nice, say, different profiles. Let me say.
I see. So what are
I never used.
Sorry, go ahead. Yeah.
I never used the MR-Linac, so when I approached with them the profiles, whoa, they are not so normal, say, at least in one direction. So it is nice to put the ends on those profiles. Nice.
So what are you studying? Some small field dosimetry?
Indeed, not exactly, not yet, because they just looking at the profiles and how to deal with those profiles, because they are, say, in one direction they are pretty similar to the other profiles, to the other FFF beams, but on the magnetic field direction they are definitely the left and right penumbras are definitely not the same. Not the same.
So what are your goals in looking at these profiles? What do you want to study?
Starting to say, on one side, to try to collect and to describe with some parameters according to what are the other FFF beams, 6 FFF.
Sure, got you.
On a side, because it is one of the machines with now more and more, but with say, no corresponding flat profiles.
So. Sure, yeah. Now so I know the group very well. I work with them, and in the past we have done a lot of research work, and I'll be actually going there next month.
Really?
December 12th, I will arrive there. That's a Monday. So we usually hold a yearly symposium on stereotactic radiosurgery and stereotactic body radiotherapy. So this year, the symposium will be held on the 17th and 18th, Friday and Saturday, December. But I want to go there a week early. And I usually go there to do an overview of the program. When I said that I used to go there 3-4 times a year, go there for just an overview of the program. Yeah.
It's nice. I'm looking at, okay, 17, 18 of December or no, November?
December.
December, okay.
Right. Let me reconfirm. It's 17 and 18. It's a Friday and a Saturday, right? Let me look at my calendar. I know it's a Friday and a Saturday.
Yeah.
So December 16th and 17th. So 16th and 17th, yeah. So and I'll arrive there on the 12th, Monday. So Monday, Tuesday, I'll spend
the week there.
Yeah. Well, I'll spend 2 days there, Monday, Tuesday. Wednesday, I'll go to our other facility in Mirabella.
Mirabella is where? Mirabella where?
Mirabella is the name of the small town. It's about 2 hours northeast if you go up from Rome and east.
Mirabella, let me check.
Mirabella, either east or west, now I'm forgetting. I think it's east. About 2.5 hours. I went there many times, driving about 3 hours, train about a little over 2 hours.
Mirabella e Clano. Close to Napoli, close to Naples.
Yeah, it's close. Yeah,
it is south. Naples, yeah. Okay.
But north of Rome, where St. Pietro is. Rome is huge, but where my reference is St. Pietro.
Yes. How many Italian centers do you have in your?
2. Somebody's recording our conversation. I just realized.
Oops, that's true. And this was told at the beginning. Yeah, you're right. Yeah.
Yeah, this session starts in 16 minutes, right?
Yes.
Yeah, I was thinking that they will join early, give us some guidance as to,
Yeah. Yeah. See, so makes sense to be not at the last minute. This is true.
So what will you be talking on?
On I don't remember. On the indeed, I was not aware that you were in this session on small field dosimetry and calculation in TPS. So it is indeed something better for you than for me.
No.
So and when I saw yesterday your name, I was saying, oh, but I didn't see in the list. So indeed, in the list I have in my hands of the scheduling of this session, you were not in.
Yeah, I thought I saw your name. I looked at the program some time ago, and I thought I saw your name and probably talking about small field.
You are going to talk about small fields.
No.
Really?
No. I thought you were talking. I thought you were talking about small field. That's what I.
And what are you talking about?
It's a QA because APM has come up with a new task group recommendation as to TG 100. No, TG 100.
Okay.
Task group 198 is a more recent one, but 100 is 198 is like giving a more specific how to implement TG 142. Yeah, how to do things.
Yeah.
And TG 100 is more like the general recommendation. That's the Bible, if you will, from AAPM as to how to do quality management. Yeah. And it's a totally different approach. It took us 13 years to write this document, printed.
Yes, I remember that the mention of the 100, a part of the number, but the mention of the 100 is quite a long time back.
Yeah, it's been 4 or 5 years. I think it was published 16. Let me see. I have a reference of this. It was published in 2016, so 6 years.
Okay.
It probably will take another 10 years to try to get it implemented around the country.
As many code of practice. Those are sometimes things that takes a long time to be published, indeed.
Yeah, but this probably was one of the longest ones, and because we took a totally different approach as to how quality assurance will have to be done.
Mm-hmm.
Not like go and do just a machine.
Not the practical things.
Yeah, measure this, tolerance this, and what we found out that really protect the patient about 10% of the times by doing machine specific QA.
Yeah.
And everything else that needs to be done, which is about 90% of the problem. So that's what made us approach the quality assurance from a totally risk assessment perspective. So I talk about that by taking SRS SBRT as an example.
Yeah.
In 20 minutes, you can't say much. 25 minutes.
No, actually, this is true.
I was given 30 minutes, actually. It said 25 to 30, and I made sure that I used every minute of my time.
It is always difficult. See, I admit one thing, that I was indeed, probably I have an old scheduling. Indeed, you are not in my old scheduling. I printed out. I was told that it was 20 minutes. And then I record my talk. That is horrible. I hate to record the talk because my performance are absolutely zero. It's horrible. I'm not able, really. It is totally different, but okay. I did, and I was staying it was 1930 something. So I was happy. I sent them and then they told me, but it is 25 minutes. Huh? What? So I had to re-record. It is terrible.
Yeah. No, First I was told 25. Then an email came and said you can do between 25 and 30. So I made sure I made 29 minutes and 55 seconds. Something like that.
That is not easy anyway to manage in the recording.
No, you just do not know. And if you exceed and you have wasted half hour, do you go back and start over because you exceeded by a couple of minutes?
In those cases, I think what I would have done if the time would have not been too much correct and just some small adjustment, just with some tools.
Okay.
Just
edit a little
bit, and then just making or slower, faster, 5% more what you need, so you can be perfect. So this could be. Yeah, this was what I was thinking indeed when they told me, okay, may I do that? And okay, I was deciding to spend another half an hour in trying to record this again. No, that's really horrible. And no, in the recording, I'm really doing a bad job for the recording.
I don't like recording either. I like more personal touch. Yeah. So how did you get connected with the Pakistan Society, the Shaukat Khanum Society?
I don't remember the first time how it was. I was invited last year too.
Okay.
And I really don't remember what was triggering this first time. Yeah, some knowledge to someone. I really don't remember.
That's good. I mean, this is good. This is a good way to get connected to the global community and make some contribution.
And the good point, okay, let's try to take the beauty of the COVID, or the beauty, what we have learned from the COVID experience. Say we can stay connected even if we stay at home. That is, and I think this is a plus. Also, say this morning I'm in Pakistan, and then at more or less normal time I'm going to start normally on my desk. That's not too bad.
And I will go to sleep, and they'll have to wake up like 5:30. I think somebody was trying to tell it. It surprises me. It's only 8 minutes left, and nobody has joined from the organizing committee.
Yeah, anyway, the good point is that they open the session, at least. The funny thing is that say it is an in-person symposium, and so we are going to join just.
I hope. I don't know what will happen in 8 minutes. Like I said, I was expecting that some of the organizers will come up and, hey guys, this is the process.
But are places where you can just at the last minute start. This is not
you have learned the system quite well.
No, I've been involved many years ago on some different country, but say with Indian people, and it is really nice in the local organization. It is the last minute, and say I grew in Switzerland. Say I worked in Switzerland for 25 years, and everything has to be very precise in the due time. It is 8 o'clock. It is 8 o'clock, maybe 5 minutes before, not after, and so it is. And the same is in Italy, and we have this funny attitude in Italy of being late, just delay everything.
I know that very well.
Yeah, and I'm still suffering. Say, having worked for 25 years in Switzerland, where everything has to be very, very strict, very precise, I'm really suffering.
Swiss time, right? All the clocks go by Swiss time, right?
Yeah, absolutely. It is not the same as Italy. And I remember once I was young, it was many years ago, and I was working in Switzerland, and we had a meeting in Italy in a center to see, and it was a special application of something. And we had the meeting, the appointment was at 11 o'clock in the morning. So I go there with my car, so some hours driving, and then arriving with a colleague. And finally, it was 10 minutes before, no one around, but really nothing prepared. There was also something related to the surgery room. So come on, cannot be. We were wrong. So trying to find someone to see what was wrong. If it was a matter of that I was wrong in the day, in the time, what I was. And then finally, 11 o'clock arrived, no one around. And then we are a bit worried because, come on. And slowly, 10 minutes passed, they arrived, and then they told us, okay, you are here. Oh, good. You are early. No. Okay. What was the scheduling? We were convinced about 11 o'clock. Yeah. It was scheduled for 11 o'clock, but it is a quarter past. Yes. Okay. This was the people start to arrive a quarter past. And then everything was starting half an hour delayed.
Oh my God.
I would have slept 1 hour more, maybe. So this is Italy.
This is Italy.
Yeah.
I saw somebody join, some Professor
But
Varun
also
Singh,
dropping down.
it dropped off. So I hope we are at the right place. You know, I wonder why, you know.
Yeah,
Okay. If Thomas has joined, then I know we are at the right place. Hi, Thomas. How are you?
I'm very well, thank you. It's wonderful to see you both.
It's wonderful to see you
Ciao,
too.
Thomas.
Ciao, ciao.
Yeah, we were wondering that we didn't see any of the organizers. Are we at the correct place?
It certainly looks like Antonella is at the right place with beautiful surroundings.
Yes.
Yeah,
yes.
Italian mountains. Indeed, it is a sort of crying mountains.
Right.
This is to mimic a nice background I saw from a Kenyan person with the crying mountain. So I found my crying mountain. This is from Italy, not from Kenya. And they keep it.
Yeah. So how have you been, Thomas? What's new and exciting with you?
Oh, the world is an exciting place, as you know, better than anyone else. But yes, no, I think the interesting part today, we had a teleconference of medical physics with world benefits, and I'll be the president next year. So I'm really sort of
congratulations.
I'm looking at, is there something medical physicists can do in order to make the world a better place? And I obviously think yes, but that's not enough.
Exactly. There is so much to do and so little that we do, the entire medical physics community. Yeah. Let's say hi to Professor Varun Singh Thakur. Hello.
Good morning.
Good morning.
Morning. Yeah, it's indeed morning here. I was telling Antolia that it's about midnight in one minute at my place.
Yeah, it's 10 o'clock in Saskatchewan. So.
Oh, you're in Saskatchewan. Okay. So you're 2 hours behind.
Yeah, I'm a clinical medical physicist in Regina.
I see. Yeah.
So
I'm also.
What
Go ahead,
time
Thomas.
are you at?
I'm sorry?
And I was just wondering what time zone Antonella is in.
It is 5 o'clock in the morning.
5 o'clock in the morning.
So she's waking up and we are going to go to sleep.
And for you, Thomas?
Very civilized. It's
civilized.
3 o'clock in the afternoon.
Super.
Oh.
So he had his coffee. Now he'll go on a siesta shortly. Italian siesta. Oh my goodness. So none of our organizers are here, I think, to give us some guidance as to.
But we are recording.
But we have been. The recording started half hour ago, and I've been talking with. Oh my gosh, Antonella! I know this whole half hour.
We have to ask to delete this first half an hour recording.
Yes, I wasn't aware that the recording was on, but here we are.
Yeah. Oh my goodness. So Thomas, will you be taking a trip to this part of the world in the near future?
This week.
Next year, yes. I've been to Europe already twice. I've been very fortunate to have to catch up with family, but also our daughter decided to study in Germany, European studies. Is that
okay?
A master's in European studies, whatever that may be, but it certainly sounds very exciting. So have to pretend to be a good parent. So I had to go as well and help her to set up. It's a good excuse.
Of course, of course.
I agree.
Will you be coming to APM next year? You said you'll be coming maybe next year.
I certainly would like to, yes. Also with this medical physics for work benefit and environment, I think I will need that. Most of the important people in that area are all from North America.
There's a lot of activities now going on with the International Council of APM, lots of activities. Yeah, and Jitender is doing a superb job as the chair of the International Council.
Yes.
Yeah, so yeah, it'll be good to, and I know he has polled all the leaders from the different, appropriate organizations.
I think it looks like a very effective group.
Yeah, it is.
Yes, and I think AAPM always has done these things very well in terms of pulling together people.
Yes, it's a somehow, there's a renewed energy within the organization, if I may say so, in the international affairs through this International Council activities. All the chairs are very active, all the different committees, and there's a lot going on globally. Yeah, so it'll be good sometime to catch up.
Yes, definitely.
So when do you take over as the president?
On the 1st of January.
Okay.
And then it's time to sort of rethink and reorganize. Jake van Dijk has started that whole process with a lot of thoughts coming from the IAA at the time, because that's where he was at the time, and we now have to sort of rethink what our role should be, and also in particular how we can bring in more colleagues from low and middle income countries. At the moment, the most successful thing has been to sponsor the virtual attendance of many colleagues from low and middle income countries at AAPM meetings.
Right.
But I think that there needs to be a bit more. Anyway.
Yeah. There's suddenly a noise that's coming up. I wonder what that is from.
Oh, that is probably me. I will mute myself for most.
Oh, no. Don't mute yourself.
No,
it's a nice noise. A nice sound. No, please, Thomas. It was a nice sound.
It gets worse. I have talked to our IT department for so many on several occasions. We cannot fix that noise, which does not appear in WebEx or Teams or any other thing, but in Zoom. So
it has gone away. It has disappeared. We don't hear it now.
It is really something which isn't. We couldn't troubleshoot that. We can do troubleshooting in Eclipse and get things right, but not in Zoom.
Oh my goodness. I guess we'll not be able to listen to our presentations. Is that what it is? Because it has started. It has started. The session should have started.
Can you please hear me?
Yes.
Yes.
Okay. So very good morning, everyone. So Dr. Saif, my name is Mohammad Abdul Rafi. So thank you for coming, Dr. Saif, Dr. Thomas Krohn, Dr. Antonella Fogliata, and Warren Tucker. So I would like to welcome all of you in this session on radiation physics. That's the 21st Shaukat Khanum Cancer Symposium. So I am joined by my co-chair of this session, Ms. Masooma Riaz. She is the chief scientist at our public sector hospital. There's an Inmol hospital in Lahore. So over to Dr. Masooma, and she will introduce the speakers.
Thank you, Rafi. We have 4 presentations in this scientific session. Our first speaker is Professor Thomas Cron. He is Director of Physical Sciences and a medical physicist at Peter MacCallum Cancer Center, Melbourne, Australia. Today, he will be talking about radiation dose. How accurate do we want to be? So, Professor Thomas Cron, please.
Do we listen to the recording or?
Yes, Dr. Thomas, we are going to start your recorded presentation.
Right, because I'm very happy to also present live, but I'm answering questions live.
So at the end of the presentations, we will have a discussion and question answer session. So we have a lot of questions there. So we'll take last 20 minutes for that.
Dear colleagues and friends, thank you very much for giving me an opportunity to talk about one of my favorite topics, which is radiation dose. Being a radiotherapy physicist, that's quite natural because radiation dose is really the therapeutic agent. But what I'd like to share with you today is really some thoughts as to how accurate do we really want to be if we report dose, if we measure dose, and if we think about radiation dose. Before I get started, though, let me briefly remind you of my potential conflicts of interest. Our institution has a Varian Medical Research Collaborative Agreement, and we also have some projects which are funded by Reflection. When I look at the present session, I'm absolutely delighted. The session covers a huge range of interesting topics, from radiotherapy to imaging and dosimetry. We are also having speakers from really all over the world. And I myself come here from Australia, this spot down there. If I magnify Australia, you can see Australia here. I'm from Melbourne, down here at the border here in the south of Australia. If one looks at Australia, most of the people live here at the East Coast, and that's where also most of the radiotherapy centers are as such. We've got about 100 radiotherapy centers in Australia. It's a mix of public and private care there, and our professional organization, ACPSEM, is also administering a certification program. The centre I'm coming from in Melbourne, Peter MacCallum Cancer Centre, is a rather large public cancer research and treatment facility. We operate on 5 campuses, operate with 16 linear accelerators, have a gamma knife, and a whole variety of other radiotherapy and imaging equipment. We offer most radiotherapy techniques and services which one can think of, from brachytherapy to stereotactic treatments, total body irradiations, and intraoperative radiotherapy. We operate Varian Eclipse system in the cloud, which really helps to distribute the information across all 5 campuses and hopefully make sure that patients, wherever they enter the Peter Mac environment, have access to the same care. We are organized in tumor streams, and that's quite important because it allows us to specialize a bit further, and it also means that physicists also specialize. For example, I support particularly the lung and the breast cancer streams. But now let's get to the topic, radiation dose. When we talk about radiation dose, then we are probably mostly talking about absorbed dose. That's 1 gray, which is 1 joule per kilogram, is the metric for that. I should just remind us that 1 joule per kilogram is actually rather small in terms of energy. If you look at a morning cereal, like just right here, it's thousands of kilojoules per kilogram. So 1,000,000 times more energy contents than the radiation dose. But the radiation dose is actually biologically effective because it's ionizing radiation, and the ionization will interrupt bonds and therefore interfere with biology. Therefore, we are not only talking about absorbed dose, we often talk about biologically effective dose, equivalent dose, or effective dose in radiation safety, which is then measured in sievert, and where the physical dose is weighted by radiation type and the type of tissue which is actually irradiated. That also applies not just for radiation safety, but also for radiotherapy. You can see here at the bottom right of that slide how in heavy ion therapy and carbon treatments, the biological dose is a factor of 2 different from the physical dose if we compare that to our more well-known conventional X-ray treatments. If I look at radiation dose, I also need to look at the target for dose. And the biological target is typically the DNA, which is in that nucleus of the cell. So we are looking really at dimensions which are well below 1 micrometer. And in that case, radiation is not a homogeneous distribution of energy, but the radiation is actually distributed in individual bits and pieces. That means that if one actually measures dose, one needs to consider microdosimetry. And microdosimetry tells us that around this sort of level of around 1 micron, there is a divergence between the dose measured and the random distributed events of ionization, which cause the biological effect. So how accurate do we want to be in terms of our radiation dose measurement? And that depends really on a number of factors. It obviously depends on how accurately we want to pinpoint the radiation dose as such. So dose in a very large volume can be hopefully more accurately quantified than dose in a tiny, tiny volume, as we just discussed in the context of microdosimetry. We also need to ask about the purpose of the measurement and about our measurement tools. How accurate can we really be? What does make a difference for cancer cure, for normal tissue toxicity, for imaging, seeing what we want to see, and potentially for radiation protection purposes? And then obviously we need to think about the cost, about the resources, about how can we actually achieve these measurements. So it then boils down really to an optimization problem. And the optimization problem is always sort of based on these type of curves, where we plot as effort, resources, time, whatever we want to throw at a problem against what we achieve in terms of the problem. So I've plotted here the accuracy of radiation dose there, and here the effort. Obviously, the more effort we put into the system, the more accurate we can actually be. But where does this point really of diminishing returns come to being? How far up this curve should we really go? In particular, at the start, when we add tiny amounts of additional effort, we achieve a whole lot of improvement. And a great example is the outcomes of the IAEA-WHO dose audits, where they do a very simple experiment. They just send people photoluminescent dosimeters, or in their past TLDs, which the user can do irradiate in a very, very simple setup as shown here. If that is right, we are really already quite a way up in terms of our accuracy, in terms of radiation dose delivery, and get a lot of reassurance. However, the accuracy we achieve with these sort of measurements is probably not as good as we really would like to be. But now, if we talk about how good do we want to be, we need to ask who is actually asking. A physicist obviously wants to be as good as we possibly can. We would like to get as close to the true value in the orange line here as we possibly can be. clinicians might be sort of less concerned about that. They would like to see their patient get treatment very quickly and very efficiently, rather than wait for dose confirmation on a very, very high level. And if I ask our administrator, well, they are mostly concerned about this effort and resources timeline, and they would like to be as far on the left as possible in order to save money. We also need to be aware of the fact that depending on what type of dosimetric tool we are using, we may actually never get to the absolutely correct value which correlates to our clinical effect here. That takes us to the effect of radiation and how accurate do we need to be in terms of making a useful comment in terms of clinical radiotherapy. If I look at prognostic factors in radiotherapy, well, cancer type and stage are the most important one. Advanced cancers are just more difficult to cure, and therefore early detection of cancers becomes such an important part. Then patient performance, comorbidities, and age are important, as are other treatment modalities. And then there's radiation dose, not right in the prime position, but certainly up there. And what you can see here is another factor where people looked at, Pulte and Brenner just looked at the cure rates at different calendar periods from 1982 to 2002, all without IMRT in head and neck cancer, and just being treated later is an advantage. There are lots of different things which come in there. Time might not be one of them. Radiation dose could be contributing, but it's probably early detection which makes a bigger difference. And we need to sort of look at the tumor control probability and its relation with dose. We want to be as high up this curve as possible and as low down at the normal tissue complication probability as possible. And it obviously, the steepness of these curves here, as the distance between these curves will determine how accurate we really would like to be. And that is something the ICIU very early in 1976 already really has looked at and derived that a 5% difference in dose, certainly in head and neck cancer, will make a measurable difference in tumor control probability and normal tissue complication probability. That is something which actually has borne out then in large clinical trials, and that just sort of shows one of the prostate trials, where you can see that in these unfavorable risk group, the difference in radiation dose, and this is a very substantial increase of dose of nearly 10 gray, really makes a very substantial difference in terms of clinical outcome to these patients, where the clinical outcome is about 50% better if we can deliver higher doses. That is not always quite as clear-cut, as you can see here in the context of normal tissues, and the Quantec data from about 10 years ago sort of shows different dose response curves, and you can see the variety of different dose response curves here in terms of pneumonitis of lung, which gets even more complicated in other scenarios. So dose may not be quite as accurate here, as long as we get it roughly right. Then that leads us to how accurate can we be in terms of radiation dose measurement. And there it is useful to look at different radiation measurement types. Obviously, all these different radiation effects, including biological effects, have been used for dosimetry. The most common is ionization in gases, in which case ionization chambers, which are air-filled mostly, are the typical example. And if one looks at the reproducibility here, you can see here, this is in a homogeneous medium, like a water phantom, like shown here on the right, looking at dose to water and looking at a radiotherapy dose level of about 2 gray. We get reproducibilities of measurement which are usually below 1%. If I do the same ionization chamber measurement, I do get better than 1% reproducibility, which allows us to get with one standard deviation to an accuracy of about 1%. That is reflected also in the calibration protocols, and that's an estimate of uncertainties in calibration protocols of megavoltage photon beams. And I've just sort of put here together a variety of different uncertainties, which you can see listed here, and look at the different protocols which might be used, look at photons and electrons, and derive here on a combined uncertainty on 95% uncertainty, so not like in the previous slide, 1 standard deviation, but here 2 standard deviations, which is of the order of 2% at best. Now, that is dose in water in very well defined conditions. If I look at a treatment of a spinal Saber treatment like this, with trying to avoid the spinal cord here and have a rather complicated dose distribution here using IMRT and VMAT and delivering 20 gray flattening filter-free beam, well, I think the uncertainty or the reproducibility of these deliveries is probably a factor of 10 worse than we have seen in that water phantom. And how accurate things are is really something which each radiation physicist would need to determine for their own environment. We certainly in real life don't even get close to what we can achieve under calibration conditions. But does that really all matter? Do our measurements really matter? And are they really measure something which is meaningful for our clinical outcome? Well, the RCP or IROC, the physical dose measurement group in Houston, Texas, which operates an auditing system, thinks maybe not. This is comparing actual phantom measurements by an independent group with the QA measurements the centers did in the night before, and they find that the institution-specific, patient-specific IMRT does really not predict an unacceptable plan as accurately as we would like to see it. In our institution, we also use different QA criteria for different treatments. For IMRT and VMAT, we would use a gamma index of 2 millimeters and 3% with 90% pass rate and threshold of 10%. But depending on what scenario we have, this can change. In pediatrics, this could be different. In stereotactic treatments, we are much more concerned about the accuracy in terms of position than we are in terms of accuracy of dose as such. So we are modifying our requirements of dosimetry depending on the clinical need. And that does make sense. If one looks at the spatial resolution, if we need to be within a millimeter in stereotactic treatments, well, we want to know things within a millimeter, but we risk then that our uncertainty of the dose measurement really goes up. And if one looks just at these two detector systems here on the right, this is a 600 cc ionization chamber. You can do very, very accurate measurements with these sort of chambers. You get lots of signal in well-confined environments. But well, the spatial resolution is obviously not great, which is quite different than if I use diodes, about 100 diodes over 2 centimeters with micrometer spacing, in which case I get very high spatial resolution, but my uncertainty is higher. And that does make sense, because dosimetric tasks in radiotherapy are not just one dosimetric task. There are a variety of different dosimetric tasks, and I just would like to invite you to briefly sort of think at how accurate do you want to be in out-of-field dose measurements or stereotactic treatments? How accurate do you want to be in brachytherapy, or can you be in brachytherapy with these huge dose gradients you have? And how accurate would you like to be in audits? Obviously, our dose accuracy is determined not just by how accurate can we be, but also how accurate is it meaningful to be. And then finally, we need to look at the competition for measurements, which are the dose calculations, which really have improved dramatically over the last couple of years. In particular, Monte Carlo calculations or the Accurus type dose calculations can be made as accurate as needed if we reduce the spatial dose calculation grid and the treat time for dose calculations. We can really achieve virtually anything. And we can achieve things which we find very hard to do in dose measurements in real life, which is, for example, scenarios with tissue inhomogeneities and motion. Easy to do in Monte Carlo if I have enough time, but very hard to do in physical measurements. So let's just look at these 4 things which look at the applicability of these Monte Carlo calculations and the limitations of the Monte Carlo calculations a bit more. Let's assume we can do perfectly well, provided we have the accurate B model and the machine actually on the day does perform as we would, as the B model predicts. And we have an accurate patient model, and the patient performs on the treatment day as it is. And that's sort of a bit highlighted here in this scenario, where I look at a variety of different dose calculation algorithms. This is Monte Carlo, and you can see here the dose distribution in Monte Carlo is quite different than a pencil beam algorithm would predict in the presence of lung. The AAA algorithm is a bit better, but it's certainly still not the same as Monte Carlo calculations as such. So as my beam model, if my beam model is accurate, I need to ask then, is my patient model accurate? And you look here at that patient where the calculation is done. It's not quite our patient, and even there are clear uncertainties which come from the use of these phantoms. There are also uncertainties which come from the dose calculation grid. And you can see here in these calculations that we are limited to a dose calculation grid, in this case of 2 by 2 millimeters, which is obviously nowhere near the DNA accuracy or the dose we would like in a stereotactic brain treatment close to the brainstem. We also have these calculations for the gantry angle of 0. And do we really know that this B model here I've stuck into the Monte Carlo is the same B model which we would have if the gantry is actually rotated to the side under 90 degrees? Do we get changes? Is the focal spot the same? Are the collimators shifting ever so slightly? So despite the fact that we can be very, very accurate with our calculations, well, we also always need to look at how well is the B model describing reality, and how accurate is the patient model describing reality. That leads Jack van Dyke then to these his famous setup of different dose requirements in different parts of the radiation beam, and that's part of the of an IAEA publication. There are a variety of different accuracy requirements which are there, and Jack van Dyke has nicely sort of summarized here. In the central ray, they are obviously much better than in the penumbra, outer beam, or even in the build-up region, where really the uncertainties become very, very high. In conclusion, why don't we want to be perfect? Well, we have a lot of things which are working against us, and probably systematic errors are the ones which are really hard to overcome. These systematic errors are patient motion. We can't predict how the patient breathes on the day, how the heart beats on the day, and all these sort of things. There is the effort, the resources, which increase dramatically, as we've discussed already. And we really don't want to put all our efforts into one patient. We really want to make sure that the majority, the maximum number of patients have access to radiotherapy and benefit from a rational beam dosimetry. In that context, we are really very close to radiation safety, where we want to be as accurate as reasonably achievable. Dose accuracy depends on many factors, including clinical need and what can be reasonably achievable. It's an optimization process which really requires all members of the team, the oncologists, the RTTs, and the physicists, to talk to each other and define how accurate we really want to be. The medical physicist, ultimate, is the person who actually can say how accurate can we be. And they have the responsibility to understand all the aspects of dose assessment in order to guide this process. This all, the accuracy we require from our applications of dosimetry and the outcomes we get in terms of that has obviously implications for patient data. Their access to treatment via the resources we can invest in that, our workload as physicists, of course, and it has importantly also impact in terms of future generation and future applications of radiotherapy. The more accurate we can tell the dose of a patient treated today, the more accurate we can link their clinical outcomes to this radiation dose and learn and learn and learn and improve and improve. So thank you very much for your attention. I would also like to thank and acknowledge a number of colleagues, and they include clinicians, therapists, they include a whole variety of people, and the Cross Foundation, which has funded our work for quite some time. So thank you very much also for your attention.
Very nice.
I note that I haven't answered the real question, but just given some ideas, because the question, how accurate do we need to be, is really something everyone needs to answer for themselves.
We will have question answer session at the end of all 4 presentations. And let me introduce our next speaker. He's Professor Saiful Haq. He's a medical physicist and director of Medical Physics, Department of Radiation Oncology, University of Pittsburgh School of Medicine, Pennsylvania. He will be today talking about quality management for stereotactic radiosurgery and stereotactic body radiation therapy. Please, Professor Saiful Haq.
Not sure.
Good morning, or good afternoon as appropriate. I want to thank the organizers of this conference for extending an invitation to me to speak at this conference. It's an honor to speak here. I understand that the Shaukat Khanum Center started their SRS and SBRT program within the last few years. So I thought I'll speak on quality management for SRS and SBRT. Here is an outline of my presentation. I'll briefly highlight the current practice of quality assurance done by the medical physicists in the clinic pretty much across the world. My hope is to impress upon you that this current practice of QA, it really does not protect the patients from being harmed. I'll discuss the rationale for adopting a new paradigm for quality management in radiation therapy, which is based on risk assessment of the processes involved in patient care. I will take SRS and SBRT as an example application of this new approach and highlight the strengths of this approach by showing various clinical examples. Almost all current quality assurance and quality management guidelines are device-centric and prescriptive. What that means is that all these guidelines tell us how to perform machine-specific QA and how often to do them and what the different tolerances are. Example of these guidelines come from, say, for example, the American Association of Physicists in Medicine, the International Atomic Energy Agency, ISRO, or other organizations. And we've been doing this for decades, and we've become extremely good at doing these machine-specific QA. It is likely that the similar practice also holds in Pakistan. But does doing machine-specific QA protect patients from the possibility of being harmed? The next slide that I'm going to show you, I'll show you some data that will actually illustrate that it actually does not. Task Group 100 of the AAPM came up with the most recent recommendations on how to perform quality management in a radiotherapy clinic. As part of their work, when they're developing these guidelines, they asked a simple question. What are the different causes of failure for IMRT, or the intensity modulated radiation therapy? This is what they found that is shown on this slide. The human failure contributes to about 30% of the causes of failure for IMRT. Lack of standardized procedures contribute 15%. Inadequate training, 15%. Lack of or inadequate communication, 10%. Hardware software failure, 9%. And then a few small others. The quality assurance, the device-specific QA that we do, that is bundled in this 9% causes of failure for IMRT. What that means is that by spending all this time that we spend in the clinic, doing all this different QA for all these different machines, we are protecting the patient from the error pathways caused by about 9% of the situations. The rest 91% of the error pathways remain open. So since one of the goals of a quality management program is to ensure that the patient receives the prescribed treatment correctly and safely, a good quality management program should be designed such that for a given process, one identifies prospectively the various failure modes, that is, things that can go wrong, the potential causes of failure, and the risks associated with them. Then place various controls in place such that these failures do not propagate through the process and cause harm to the patient. This is the TG100 risk-based approach, and this should be done in a prospective manner. So TG100 recommended, or the Task Group 100 recommended 3 tools for developing the risk-based program. They are process mapping, failure modes and effects analysis, and fault tree analysis. I'll talk about only process mapping and the FMEA because I do not have time to really give a brief overview for all the 3 the tools. So I'll not talk about fault tree analysis or FTA. So what does a process map looks like? What is process mapping? This slide shows a simple example of a 30,000 feet view of one type of process map of a patient undergoing external beam radiation therapy. On the left here, it shows this is where the patient starts treatment, and the central arrow shows the progression of the treatment. The patient first goes through consult, then does CT simulation, treatment planning, plan checks, imaging, treatment delivery in that chronological order. This is just an example of that. Each of these consult, CT simulation, planning, plan checks, imaging, or treatment, they're known as sub-processes. And at each of these sub-processes, many activities happen. For example, during consult, patient completes medical history. The nurses complete H&P, and they are documented, right? For CT simulation, you immobilize the patient on the CT simulator table, and then you scan the patient, you mark the isocenter, and many other things happen. So at each of these sub-processes, there are all the different steps that happen. Your goal is to document all of these steps, and thereby you have in front of you an entire process map and you have in front of you all the steps that the patient touches from the time patient walks in till the time patient walks out. And so for a patient to receive the prescribed treatment correctly, at every step of the process, things the way they are supposed to occur, they should occur exactly the same way. If some errors happen at any of these steps, then that error has the potential to compromise care to the patient, and the patient can get harmed. So this is the first step. That's the process map, and you identify all the steps in the process map. Once you have done that, then this process map and all the steps are used as an entry point for the next tool, which is known as failure mode or effect analysis, or FMEA. So what is FMEA? It's a risk assessment tool. It is used to identify weaknesses or deficiencies in processes. It's a step-by-step approach for assessing potential failure modes in a clinical process. And the purpose of FMEA is to prioritize the potential failure modes for preventive actions and make the radiotherapy system safer. So let's take SRS and SBRT as an example application of this approach. So we start with the process map for SRS SBRT. Again, this slide shows a very high level view of what an SRS SBRT process map may look like. Patient selection, diagnostic imaging, immobilization and CT simulation. You do treatment plan, and then the physicists go and do a plan specific QA. You do patient setup and imaging, and then you deliver treatment. So it's a very high level process map. So once you have that, then you ask the question, what can go wrong at each of these steps? These are what I mentioned and known as the failure modes. And your goal is to prospectively identify every possible failure mode, everything that can go wrong at each of these steps. Here, I have identified, just as an example, highlighted a few failure modes that can occur at each of these steps. For example, for diagnostic imaging, one of the things that can go wrong is that image resolution or slide spacings are not adequate. For immobilization and CT simulation, you may be using a poor technique in creating mold or mass. That can go wrong. Treatment planning step, the fusion that you do may not be doing correctly the image fusion, so that will have an impact. And similarly for the other steps. So these are all known as the failure modes. So as you can see that when you do just a machine QA and patient-specific QA, those will not address all the different errors or the failure modes that can occur in each of these patients. So in order for these patients to get correct treatment for SRS SBRT, you'll need to identify all these failure modes. And once you have identified the failure modes, then you ask the questions, what can go wrong at each of these failure modes, how likely they can happen, and what are the impacts that it will have on the patients. And once you have done all of those, then you can identify all the different controls that you can put at each of these steps so that those failure modes do not propagate from the point of origin till it harms the patient. That's really the idea of this entire approach for development of a quality management program. So let me show you some examples, clinical examples of, at each of these steps, what the different failure modes are and how do you go and analysis. For the diagnostic imaging, I mentioned that one of the failure mode is image resolution, slide spacing is not adequate. We know that diagnostic MR scans are routinely acquired with a slice thickness of 5 millimeter. On the left, you see a contrast enhanced T1 weighted MR image with a 5 millimeter slice thickness. And on the right here, you see a contrast enhanced SPGR sequenced image with 1.5 millimeter slice thickness. As you can see here, with a coarse slice thickness MR scanning, you would have missed detecting this small occipital lesion. So that's something that can go wrong, and you will not be detecting this because the image resolution spacing not being correct, you'll miss detecting that particular occipital lesion. So you ask the question, how can it happen? Well, you may not have the standardized CT or MR protocols for radiotherapy planning. There can be lack of policies and procedures, lack of training. So all the causes that can contribute to the occurrence of this failure mode, you identify them. Then you ask the question, what effect will it have on the patients? Clearly, if you miss detecting this brain mets and you do not treat that, that can have severe impact on the patient. So now that you have identified all the causes for this particular failure mode, you ask yourself, what kind of quality control you can put in place so that this failure mode does not occur? Clearly, one of the controls that you put in place will be establishing an appropriate imaging protocol that is specific to SRS treatment. You can have develop policies and procedures for cranial imaging for radiation therapy and other controls that you can think of. You identify all of that. Here is another example for things that can go wrong during the immobilization and CT simulation step. Things that can go wrong, the poor technique in making masks or mogs. On the far left, you see that the mask system that is used, for that we use a Q-fix mask. This is the mask that we use routinely, say, for example, for immobilizing patient for SRS treatment. The middle image shows a CBCT of a patient when the patient setup on the mask is good. As you can see, the patient is pushed in all the way, and the back of the neck is resting very well on the mask. Okay, and back of the head is also nicely resting on the cushion there. However, the same is not true on the right image. Here you can see the patient is not pushed in all the way in the mask system, and the neck is not resting on the where the neck should be resting, and the patient will be very uncomfortable in a situation like that, and that will facilitate movement of the patient inside the mask because the patient is not comfortable, and that will result also in image matching. So how can it happen? How can it happen? It can happen because the therapist may not be well trained, or even if the therapists are well trained, they may be rushing because you have a lot of patients, waiting in the queue, and they have to finish everything within a given day. And there may be many causes. Do you document all of that? What effects can it have on the patient? Well, if the mask is not made right, the patient will move inside the mask. And then the target volume and OR volume that you have drawn and developed your treatment plan, the patient may not be in the right location, and you may underdose the target and overdose the organs at risk. What quality control you can put in place to mitigate that? Well, the first thing obviously is to train the therapist or improve techniques, or if you're shortage of therapists, then you make sure that you have the appropriate staffing in place. Another example of things that can go wrong in immobilization and CT simulation step is poor CT scanning technique. We know that patients with irregular breathing pattern are not good candidates for treatment with free breathing gated treatments. Irregular breathing gives rise to image artifacts. As you can see here on the left image, there's a lot of artifact here. Which is a free breathing CT. But on the right, on a single phase 4D CT, you do not see those artifacts. So how can it happen? Well, if the patient breathing pattern is irregular, then that can give rise to those. If the patient is not compliant, and if the patient is not breathing regularly, not compliant, then that can also give rise to patients to this kind of imaging artifact. So what effect will it have on the patient? Obviously, you can see the target volume that you have drawn on the left and the right are significantly different. So it will be an incorrect delineation of the target and potentially OAR controls. And so it will have an impact on the doses that you deliver on the target and the organs at risk. So now that you have all the causes in place, you ask the question, what kind of quality control or QA you can put in place so that this kind of image artifacts don't happen. One possibility may be you coach the patient so that the breathing pattern is a lot more regular, or you develop appropriate protocols for patient selections and so on. Another failure mode for this, the poor 4D CT scanning, one of the impact of that, you can see that the irregular breathing pattern can give rise to this piano key motion artifact on the sternum and potential spurious locations of target in the reconstructed images. As you can see, the appearance of the tumor volume at two different locations in the reconstructed images. Again, this happens because of the irregular breathing pattern or non-compliant patient or more. And obviously the impact on this will be delineating the incorrect target and organs at risk volumes and impact on the doses to the targets and organs at risk. The quality control that you can put in place again is, you coach the patient or you develop appropriate protocol for patient selection. For the treatment planning step, one can identify many failure modes. An important one is image fusion. Here you see on the left an example of automatic image fusion of a low resolution, short scan range MR image with CT images. Because the MR scan range is short, this automatic fusion resulted in a displacement of one whole vertebral body. It is difficult to tell the vertebral level in this limited MR range series. In this example, the physician's intent was to treat this vertebral body, but the fusion was done on that particular vertebral body. So you can see that the treatment would have missed completely the target, fully one vertebral body. So how can it happen? So this is this auto fusion of short scan range MR image with the CT image that contributed to this. If you had an experienced physicist or somebody who's doing the physician fusion, they would have caught it. So there may be lack of training, of the professionals who are doing this image fusion. Or maybe you may be trained, but you're rushing to do this. So there may be many causes that can contribute to this. And the impact on the patient, well, if you have missed a whole vertebral body, you did not treat the patient correctly. And this could have severe impact on the patient treatment outcome. So what controls can you put in place so that these things do not happen? You pay close attention to fusion process. This is really critical, in doing any SRS SPRT treatment. You need to have appropriate policies and procedures so that maybe you can have a policy so that multiple professionals, the physicists, the radiation oncologists, the surgeons, they're involved in the fusion process prior to contouring. Another failure mode for the contouring is incorrect contouring of the trachea or bronchus. Only the lumens are contoured, but not the wall. So for central lung SPRT, the contour of the trachea and bronchus should include contouring the entire wall, but you may be doing contouring only the lumen and not the bronchial wall. How can that happen? Because there's a lack of training and of the professionals who are drawing the contour or inexperienced people performing the fusion. And that you may not have any policies as to how to do them. And if you do that, what effects will it have on the patient? Since the contours of the trachea and bronchus are not, it includes only the lumen and not the bronchial wall, the DVH of these structures will not accurately reflect the risk of complication post-treatment. So what can you do to prevent this? You provide training, to the professionals that, hey, when you're drawing the contours for the trachea or the bronchus, you should include the entire wall and not just the lumen. You should develop an appropriate policies and procedures for contouring walls. For the setup verification, here is an example of the availability of 3D versus 6D technology and what impact that can have on the alignment. What can go wrong? It's an inaccurate localization. Here I show you a patient with the 4 METs. And I hope you can appreciate and you can see the yellow and the red, the contours show the misalignment in the target localization due to differences in the availability of 6DOF versus 3DOF tables. So how can it happen? Well, you may be treating your SRS patients with a technology, the table, that can only do 3 degrees of freedom alignment, but not 6 degrees of freedom. Or even if you may have the technology, but the professionals who are matching these, they may be inexperienced in image matching. You may not have any standard guidance for matching and planning. The impact on the patient, there can be partial miss or geographic miss of the target. Here is shown the differences in the dose distribution from the 3D versus 6D match. As you can see, there are significant differences in the coverages by the prescription dose as shown by the color wash in all these different images. So what quality control should you have in place? Well, if you're doing really intracranial SRS, it will be important to have availability of your 6DOF table and provide training and develop standard guidance. Here you can see the lack of coverages, by looking at the DVH. The 4 solid lines show the correct DVH for the 4 targets, and the dotted line shows the DVH because of the misalignment. As you can see, how we can totally miss the target. So I have shown you, given you some clinical examples of how at every step in the process, how things can go wrong, and then how you can identify the different causes that contribute to the occurrence of how things can go wrong or the failure mode, what impact they can have on the patient, and what are different quality controls that you can put to mitigate those. So once you have that, then the protocol gives you the next step as to how to quantify these failure modes and if they occur, the severity of the patients. And I really don't have time to go in detail, but I'll give you a very simple example. So once you've identified, gone through the FMEA, or the analysis that I've shown you so far, then the next step is to determine the likelihood of occurrence of the causes of the failure mode. The occurrence is often rated on a scale from 1 to 10, where 1 is extremely unlikely and 10 is inevitable. And this occurrence is signified by the symbol O. Then you also determine the consequences of each of the failure mode on the patient. In other words, this is given by the severity rating, what impact the failure mode will have on the patient. And the severity rating also goes on a scale from 1 to 10, where 1 will indicate an insignificant impact on the patient and 10 will mean catastrophic. Then you determine the likelihood of detection of the failure mode. If the failure mode occurs, will you really catch it? And this is given by the parameter here, D, which also ranges on a scale from 1 to 10, where 1 means that you have enough control in place that you are likely to detect the failure mode if it occurs, and 10 means the controls are not likely to detect the failure mode. Then you calculated a hazard index known as RPN, or risk priority number, which is given as the product of O, S, and D. So RPN then ranges anywhere from 1 to 1,000. A low value of RPN means that particular step at which that failure mode occurs has a low hazard, and a very high value of RPN means that particular step is very hazardous. That means you do not have enough control in place to mitigate those hazards. Similarly, a high value of S means that particular step has a severe impact on the patient, and a low value of S means that low impact. So for every step, then you assign values of O, S, and D, and you calculate these RPN values. And here, as you can see, that just as an example, I've shown you 3 cases. The RPN values range in these cases from 72 to 729. So this is a very high RPN value. You can immediately see that since this has a very high value of RPN compared to those 2, this is the most dangerous steps in your quality management process. Similarly, these 2 steps have a very high value of severity, say 9, compared to this step. That means these 2 steps, if these failure modes occur, they will have a severe impact on the patient. So this way you prioritize all the steps from the highest RPN value to lowest RPN value and the highest severity to the lowest severity. Once you have that, then you go and identify those steps and determine what are the weaknesses of that, what are the causes that are contributing to this high value of RPN or S, and then you put appropriate control in place so that you can mitigate the occurrence of the causes that contribute to the occurrence of this failure modes. And then once you have done this, then you come back maybe 6 months later and then reevaluate that by placing the appropriate control. Have you minimized the values of RPN lowered or the severity? So this is really the concept of the development of a risk-based quality management program. The task group recommends that you perform this entire analysis by putting a team together. All the professionals who are involved in the care of the patients should be involved in this, in the generation of this process mapping, FME and FTA. It's a radiation oncologist, the medical physicist, the dosimetrist, the therapist, the IT personnel, the administrator, they all should be involved in this. And this effort should be facilitated by somebody who is experienced in that. Well, with that, I want to acknowledge my collaborator, my associate director in my organization, who helped a lot in the preparation of these slides. Thank you very much.
Thank you, Professor Saiful Haq. Ara? Okay. Our next talk is by Dr. Antonella Foglietta. She is a medical physicist and clinical research scientist at Humanitas Research Hospital and Cancer Center, Milan, Italy. She will be today talking about small field dosimetry and calculation in treatment planning system.
Good morning. My name is Antonella Fogliata. First of all, I want to thank the organizing committee for the invitation to this 21st Shaukat Khanum Cancer Symposium. In the next 20 minutes, I will briefly give you a few hints on the very complex and big chapter of the small field dosimetry and calculation. This is the agenda of my talk, going from the physics points characterizing the small fields through the TRS 483 code of practice of the output determination. And then I will present an example of the Eclipse TPS regarding the accuracy of the small field dose calculation. Starting mentioning the clinical rationale of the small fields, which comes from the stereotactic radiotherapy, where we can deliver very high dose per fraction since we treat small target volumes, that means small fields. But also in those treatments, we need to be as accurate as in all the other treatment of the radiotherapy. But what is a small field? Can we just give a dimension to discriminate between the small and the traditional field size? Which is the difference in small fields in relation to the traditional fields? We can find some good discussion points and some answer in these fundamental publications of the IPEM on the small field dosimetry. This is the report number 103, and it is a document that opened the door to the code of practice in the small fields. The code of practice that today's are available are the IAEA TRS 483 from 2017 and the AAPM TG 155 from 2021. I will focus my attention on the TRS 483. Also, the two documents share the same definitions and the formalism. And the formalism was previously published in 2008 on medical physics in the Alfonso paper. First, we have to understand a bit of the physics of the small fields that are characterized by three factors: a loss of lateral charged particle equilibrium on the beam central axis, the collimating device which partially obscure the primary radiation source, and the size of the detector that is small, similar or large compared to the field dimension. Let's see one by one those characteristics. I will start from the loss of charge particle equilibrium. When the radius of a narrow field becomes small in comparison with the maximum lateral range of the secondary electrons, we are in presence of large charged particle disequilibrium. This disequilibrium increases with the beam energy and decreases with the medium density. The TRS-483 gives indications of this range in water as a function of the beam quality as TPR 2010. To quantify this range from this formula, for example, for a 6 MV beam with a TPR 2010 about 0.66, 0.67, the range of the lateral charge particle equilibrium is around 1.2 centimeter, meaning that a 2 by 2 centimeter field is physically to be considered small. And then the second point. It is known that the radiation source is not a point source, while it has a finite size. In broad fields, the observer, that is the point of the dose deposition, is entirely seeing the radiation source. While reducing the collimation, the observer does not anymore fully see the source. And you can imagine that any effect related to the partial occlusion of the source will depend on the radiation spot size and shape. The first effect of the partial occlusion of the source is on the penumbra. We can geometrically define the penumbra as the region where a collimating device on each side brings the observer from inside the field where the source is fully visible to outside the field where no source is visible. Here is the case of a broad field with its profile. And here is the case of a small field where you can see that the two penumbra, left and right, overlap. In the profile plot here on the right, we can simply overlap and combine the two penumbra that are in the blue profiles to obtain the small field profile that is shown in red. And then when we renormalize this profile, we can consider the dosimetric field dimension as the full width at half maximum, we will see later. In this way, an apparent widening of the field size is shown in the small field case. The other effect of the partial occlusion of the source is a significant reduction of the output for small fields, since the source is not going to fully contribute to the dose deposition point, since it is partially shielded. And finally, the last point of the physical conditions of the small fields is on the detector size. A field is considered small for dosimetric purposes when its dimension, that is in yellow in this picture, is small, smaller than the sum of the detector radius plus the range of the lateral charged particle equilibrium, as expressed by the previously mentioned formula. In such conditions, we have to speak about small fields again. So it is now clear that the field size definition in small field is a fundamental characteristic. The dosimetric field size can be defined as full width at half maximum of the lateral profile. In the broad beam, these equal the geometrical field defined by the collimation opening. In small fields, the apparent widening of the field size makes the dosimetric field different from the geometrical field. And in particular, it is larger. Here in this plot, I report what was shown in the Kramer-Sargison work. They proved that the full width at half maximum is better representing the output variation than the collimator opening. Indeed, in the TRS 483, the small field size is indeed defined as the full width at half maximum. The TRS 483 code of practice indicates how to measure small fields, in particular concerning the output factor. We have indications on the suitable detector that clearly not all the detectors are suitable for small field measurements. And we have also indication on the definition of the field size equivalence. In small fields, we don't have to equate the scatter condition as we do normally with the broad beams. What we have to do is simply to consider equivalent areas. So the equivalent field size of a rectangular field is the side of a square field with the same area, which is the square root of the product of the two dimensions. Once the field size is so defined, the output factor is the ratio of the readings corrected by the output correction factor, which is tabulated in the TRS 483 for different machines and for these different energy conditions. Here in this table 26 is the field output correction factor for MLC-based LINAC, 6 MV beam quality, indeed it is MLC or cones, for a series of detectors and as a function of the equivalent square field size. Here is the same, but for 10 MV beam. The previous tables are based on published data, shown also in many of those plots published in the TRS 483. In the green contours, you can now argue the overestimation of the solid state detectors, presenting a correction factor which is less than unity for very small fields. While what is shown in the orange boxes, the volume effect of the ion chambers is shown to correct the factors with a factor larger than unity for small fields. Exactly the opposite behavior. Up to now, we have seen the dose measurements with the TRS 483. Now I'm going to explore the dose calculation. As a first point, we need to understand which are the parameters inside the algorithm which influence the dose calculation accuracy in small MLC-based fields, and how they are managed inside of the TPS. I will take a practical example from Eclipse TPS, the treatment planning system Eclipse. In Eclipse, we mainly have two sets of parameters. Those describing the multi-leaf, which are the transmission and the dosimetric leaf gap, and the effective spot size. Let's start with the first, which are declared to affect the output factor, the output of the small fields. The leaf transmission is a concept easy and can be measured just as a ratio between the readings of an MLC closed field and the corresponding open field. The dosimetric leaf gap can be defined as the full width at half maximum of the radiation peak of the profile generated by opposed closed leaves. Eclipse during the planning with MLC, particularly with IMRT and VMAT, initially uses the fluence according to the geometrical field, and then enlarges the fluence by the dosimetric leaf gap amount, half per field side. Considering that typical dosimetric leaf gap is of the order of 1 millimeter, this value becomes important for small fields that are fields maybe of the order of 1 centimeter size, while for large fields, this millimeter is becoming practically negligible. The question that could arise is, which is the consistency between the actual, what we measure, and the calculated field size? And then the second set of parameters, which is declared to affect the output of the small fields, and also the penumbra of all field sizes. Regarding the effective spot size parameter, we have two values, the spot size in X and in Y direction, and we have to set them manually. If we look at the values suggested by the vendor that are presented here in the table, they seem to indicate that they are mainly used to adjust the calculated penumbra in terms of JO or MLC definition. In practice, we should set the values according to what we mainly use clinically, and then consistently check calculations against measurements with MLC, measurement acquired with very high care. Here is an example of profiles and penumbra calculated with different spot size parameters and compared with measurements. It is shown here what is physically expected. The larger the spot, the larger the penumbra. And then from the penumbra to the output. In this work, we reported about the output of the small fields generated by the MLC. In this case, an HD MLC, high definition MLC, with 2.5 millimeter leaf width. The measurements were acquired with a diamond detector and were corrected similarly to the TRS 483. Those data were then compared with the calculations using AAA and Acuros algorithms. The calculations were done using 1 millimeter grid size. That is an important parameter to set for the small fields, for planning, but also for checking and evaluating against measurements. Here in this plot, you can see the results as a difference between the calculated and the measured dose for Acuros on the left-hand side and for AAA on the right-hand side. The three set of data show different DLG values, and in the middle, it is shown the measured value setting. The DLG, as expected, plays a role in the small field output, not the larger. And the end results show better performance from Acuros with respect to AAA. In this figure, I want to show you the consistency of the field modulation in few VMAT cases that are shown in the different rows of this matrix by varying the dosimetric leaf gap. In this matrix, the first column shows the APID acquisition converted in dose in water. In the next columns, the dose is calculated for increasing dosimetric leaf gap values. You can see that by increasing the DLG, the dose is becoming less and less blurred, more similar to the APID acquisition. And then it is going to recover some modulation, increasing the DLG. Let's now see the same kind of data, but varying, instead of the DLG, varying the spot size. Again, Acuros on the left and AAA on the right. And again, for very small fields below 1 centimeter, the influence of this parameter is very important, especially for AAA. Again, similarly as before, in the first column, we have the APID measurements and then the calculations with increasing spot size. Again, we can see that by increasing the spot size, the dose becomes more and more blurred, losing the modulation with respect to the delivery. So, in summary, we should prefer slightly larger DLG and probably smaller spot size. Finally, let's see a possible impact at the planning level. Here is a case of an acoustic neuroma planned with a VMAT SRT. The calculations were made with different configurations according to different settings of the spot size and the DLG parameters as summarized in this slide. This is the target DVH just focused on the high doses. For the calculations of the same identical plan with the same identical monitor units, using different dosimetric leaf gap. Just to have an idea of the values, the DLG01 can be the DLG of a dual layer MLC. The 04 is similar to the HD MLC. The 1 millimeter is, for example, for a Millennium MLC. So those values are measurable on real machines. And you can see that the difference of the median dose is important, and it is around more than 3%. Is it physically acceptable? Well, questionable. I would say no, it is not so acceptable. Is it clinically relevant? Maybe yes. So we have to pay attention and set, adjust, fine-tune the proper DLG value in order to have a physically and clinically acceptable results that are consistent between measurements and calculations. Similarly here, using different spot size parameters. And I think that the clinical impact of all those parameters, spot size and the DLG, is of a kind of interest, possibly even clinically. So to come to the conclusion. The risk of a wrong estimation of the output, be it from measurements or from calculations, can have a clinical consequence. Here is a case of a lady treated with radiotherapy for a trigeminal neuralgia. The upper picture is the patient before the treatment, and below the same patient after radiotherapy treatment, when several times during the day she suffered from a facial spasm. And the reason? An overdosage of a factor about 2 generated by a wrong estimation of the output factor. So this is bringing to the conclusion and the summary of this talk. The small fields are widely used today in the clinical practice with stereotactic treatments. And the physics of the small fields is complex due to the loss of lateral charged particle equilibrium, due to the partial occlusion of the radiation source, due to the detector size, which is large in comparison with the field size. However, we can rely on important documents as the TRS 483 Code of Practice to determine the output of the small fields. The open question remains the accuracy of the treatment planning system for those spatial fields, considering that we are treating the patients according to what we see at the planning level. Remembering that with the measurements, we can just check the calculation. In the practice, with the eclipse example we have seen, we can attempt to improve the consistency between the calculations and the measurements with the tuning of, for example, in eclipse, the spot size and the resimetric leaf gap parameters. And my final remark is that we have to supervise and carefully check the calculations according to high quality measurements. And this is the work of the physicist. Thank you for your attention.
Thank you. And we have last speaker for today's session, Mr. Varun Singh Thakur. He's a medical physicist from Ellen Blair Cancer Center, Regina, Canada. He will be talking about stereotactic radiosurgery, quality control overview, and planning challenges. Mr. Thakur.
Hello, everybody. My name is Varun Singh Thakur, and I'm a clinical medical physicist in Regina, Saskatchewan, Canada. Thank you for giving me the opportunity to talk about quality control and planning challenges for stereotactic radiosurgery. A little bit about our center. Saskatchewan is located right in the middle of Canada, and we have 2 cancer centers. One is in Saskatoon, and the second is in Regina. Both centers are roughly of the same size. We are mostly variant environment. We have 3 true beams in each center, and we have Eclipse as a treatment planning system, and we have ARIA-RO as a record and verify system. I do not have any conflict of interest to disclose. The overview of the presentation is such that presentation is divided into 2 sections. First, I will discuss quality control overview, and in this, I will talk about small field commissioning, end-to-end testing, Winston-Lutz test, and machine performance check. Machine performance check is a variant product designed for the true beams. The second section of the presentation is the planning challenges. I'll be talking about the dose constraints, the plan quality metrics, SRS planning challenges, and I'll also touch on HyperArc. HyperArc is, again, a variant product specifically designed for SRS treatment planning and deliveries. So starting with the quality control overview, When a center started discussing starting a SRS program, one of the first challenge that they face is the small field commissioning. Small fields poses their own challenges for the measurement because of the issues either related to the beam or to the detector itself. For the beam related conditions, it could be like lack of lateral charge particle equilibrium or source occlusion. Source occlusion is when jaws are so close to each other that they shadow the source. And for the detector related conditions, it could be volume averaging. Volume averaging is when the size of the detector is comparable to the field size. Or the other challenge could be the response of the detector material to the beam spectrum. This presentation is put together in a way that I will discuss how we tackle these issues in our institute. So for the small field commissioning, we followed TRS 483 report. And this is a joint report from AAPM and IAEA. We followed this report to measure the output factors on our 4 true beams, 2 from each center. And we did this for 6 MV, 6 MV FFF, and 10 MV FFF. And the average of these measurements, these output factors, were used into our treatment planning system for the beam models. These are the equations that we used from the TRS. This is called daisy chain approach. And in daisy chain approach, you use a small field detector. Like in our case, we use PTW 60017 for small fields. And then from intermediate field to the machine specific reference field, you use a detector that does not need small field corrections. And in our case, that was a pinpoint detector. So in our situation, we used 4x4 centimeter scale as a intermediate field. So for the field sizes smaller than 4x4, we used our PDW diode. And for field sizes 4x4 or larger, we used pinpoint chamber. And that, as far as the orientation of the diode goes, it was placed perpendicular to the beam axis. And one extra thing that we did was we measured lateral profiles for every field size where one of the axes of the field size was 1 centimeter. And this was done to make sure the measured profile matches with the profile selected, measured field size matches with the field selected at the machine. And if it wasn't, then the TRS correction factors were interpolated accordingly. To position the chamber at the center, we started with the center check functionality on our water tank, and then further tweaked by moving the chamber into small steps and trying to find a position where the maximum signal was measured. These are the results from our small field commissioning for all 3 energies across 4 true beams. And these are the average values that we got. And we got fairly good agreement between all 4 machines. And these average numbers were used in the treatment planning system. So once treatment planning system is commissioned, then moving on to the machine specific requirements for the SRS type of treatments. Task group report 142, which is again AAPM report, talks quite in detail the recommendations for the machines that are used for SRS or SPRT. Task group recommends the coincidence of radiation and mechanical isocenter should be within ±1 millimeter from the baseline. And for the onboard imaging, the imaging and treatment coordinates should coincidence should be less than or equal to 1 millimeter. There are many commercial Khanum availables that one can use for these tests. There's even a sun nuclear Khanum available that is specifically designed for single isocenter multi-med types of treatments. In our center, we simply place a ball bearing machined at the end of the metal rod, and the isocentric movement of different gantry, collimator, and couch angles is determined by measuring the distance between the center of the ball and center of the radiation field. These are the results from our last 20 or so Winston Lutz tests. This average number of 0.66 millimeter is the combined number of gantry, collimator, and couch orientation. And if we divide it individually between gantry, collimator, and couch, we were around we were less than around 0.4 millimeter on average. We also implemented a machine performance check, which is a variant tool for the true beams. They use ISO-Cal Phantom. And we implemented this for two main reasons. First was the ease to use this as a tool. And the second intention was this could also further verify our Winston-Lutz results in terms of our isocenter size. And as it's shown here, the isocenter size from the gantry or from the couch is either 0.4 millimeter or less than that. One other important aspect of any SRS program is the end-to-end test. There are many commercial phantoms available to do this. And the idea here is we use this phantom and have this phantom goes through all the steps that a patient would go through, and then try to calculate the overall target accuracy and the dosimetric accuracy. In our institute, we went with a phantom named Steve. It's a CIRS phantom. This phantom has some bony structures in it, such as spine, teeth, brain, and it also comes with inserts for different detectors, such as films or pinpoint chambers, and it also has some MR compatible inserts as well. These are the pictures from our phantom. We used EBT film for the target accuracy, and we used pinpoint chamber for the dosimetric accuracy. And if we followed the same steps that we would for a SRS patient, we CT the phantom using the same protocols that we would use for the patients. We did the planning and dose computation following same approach as we would use for the patient, and then image guidance was used for the positioning at the treatment couch, and then the dose was delivered. With the EBT film, we were able to achieve a target accuracy of less than 1 millimeter, and that was done with the MATLAB tool. This analysis for the pinpoint chamber measurement, we were able to show that our measured dose was within 3% of the planning dose. And for the external validation of the end-to-end, we borrowed IROC Houston's SRS phantom. This phantom has some TLDs in it and films in it for the dosimetric measurements and for the target accuracy. The results of these reports seems clinically acceptable. We got the ratio of the delivery dose to the planning dose at the center of the target was 0.99. We were pretty happy with that. And the gamma passing rate was 99% and 100% between the two films. And the gamma passing criteria is a little loose for these tests. It's 5% for dose difference and 3 millimeter for distance to agreement. So these were the things that we did specifically for SRS in addition to our regular QA that we have on our machines. Now moving on to the treatment planning side of the presentation, let's first talk about the dose constraints. There are many references out there that talks about the dose constraints for the SRS treatments. And one of them is, again, AAPM report 101. They talk about the dose to some of the OARs based on if it's a single fraction, 3 fractions, or 5 fraction treatments. But this report came in 2010, and last year, results from high-tech report came out as well in 2021. In high-tech, they not just looked at the normal tissue complication probability, but they also look at the tumor control as well. So they came up with the new guidelines that we are adopting in our clinic right now. All right, so once a plan is ready, we have to come up with some metrics to evaluate the quality of the plan. One of the very standard index used for this is the conformality index, which is simply a ratio of prescription isodose volume to the target volume. There's also a Paddock's conformality index, which in addition to looking at the prescription isodose volume and target volume, also looks at the volume that is included in both structures. So in this way, if prescription isodose volume is exactly equal to the target volume, that doesn't mean its score would be perfect. Score would only be perfect if they superimpose on each other perfectly. All right, and for the dose fall off outside the target volume, there's a gradient measure index, which is given by default by CLIPS, and it's the difference between the equivalent sphere radius of the prescription and half of the prescription isodose. Other index one can use for the dose fall off is the gradient index, and it's the volume of half of the prescription isodose to the prescription isodose volume. So these are the metrics one can use to evaluate the plan. Now, let's talk about the planning process itself. So here I'm outlining a couple of challenges that we have to deal with for SRS. First one is the isocenter selection. And this is crucial nowadays because quite often we treat single isocenter multi-met treatments for a LINAC-based SRS. And this is crucial. Selecting the perfect location for the isocenter is crucial because depending how far off your targets are from the isocenter, your rotational uncertainties can have a bigger and bigger impact. The other challenge with the SRS is use of couch kicks, and this is necessary because we want to use a non-coplanar beam arrangement. Then we have a collimator angle selection. There are publications out there that have proven that the collimator angle impacts the low dose spillage of the SRS plan. So selecting a perfect collimator angle is very crucial. And then we want a sharp dose fall off outside the targets. And we usually achieve this by using ring structures. And there are many recipes out there which talk about these ring structures and their priorities. Then last but not the least is the normal tissue objective parameters like the shape of the NTO. And there are papers out there that discuss their own planning strategies for SRS planning. For us in our institute, we recently acquired HyperArc. Our other center, Saskatoon, does not have HyperArc, and they have a SRS program going on from a couple of years, and they use a standard VMAT approach for their planning. But in our center in Regina, we decided to go with HyperArc from the beginning because HyperArc is a product by Varian specifically designed for the SRS type of treatments. It has two sides, one on the planning side, one on the delivery side. And I'll be mainly talking about the planning side, like how HyperArc deals with all the challenges that I pointed out in the previous slides. So first of all, HyperArc can select the isocenter location based on all the PTVs that are to be treated. And it's usually use the center of mass of different PTVs to decide the location of the isocenter. As I'm trying to show here in this example that HyperArc placed isocenter close to the bigger target here. And the second is the collimator angle. For collimator angle, it has an additional algorithm that it uses to decide the perfect collimator angle based on how many targets we are treating and what the location is. And this algorithm essentially tries to reduce the island blocking. So what it means is whenever possible, it tries to have a given pair of MLC leaf treat only one target. As I'm showing here in these two pictures, 1 and 2. In picture 1, there's no blocking of island, but in picture 2, you can notice that every leaf pair is used to treat only single target. And for SRS NTO, it uses a spatial upper dose constraint indexed with I. And the idea here essentially is to simulate those ring structures that otherwise are manually contoured and then prioritized in the optimizer. HyperArc tried to do it automatically without planner has to actually create these ring structures. Planner still can create ring structures if they want to, but they don't have to. And these constraints are usually based on the size, shape, and position of each target. And there are publications out there that compare HyperArc with the VMAT. And this is one of the publications with quite a few patients in it. And we also did a little bit of in-house investigation on how HyperArc fits in our workflow. I'll only be showing a small section of the results because I wouldn't discuss, I can't discuss too much detail at this point because the study is not approved by the ethics committee yet. But what we found was when we took our institute's SRS patients that were treated in Saskatoon, we replanted them with HyperArc, and the intention was that the minimum user intervention is done for the HyperArc planning. And that was very intentional because every time we do a planning study, it's difficult to stay fair with the treatments that we are investigating, the techniques we are investigating. So for HyperArc plans, we didn't use any ring structure, first of all, and all the optimizers were run 2 times without really user changing the too many parameters of the plan of the optimizer. And in conclusion, what we found was the HyperArc plans was showing the same conformality as our manual VMAT plans taken from our other institute. And but the HyperArc plans showed improved gradient, which was statistically significant, and it showed lower modulation in plans, and the lower modulation also leads to having less number of MUs, which leads to having a faster delivery. And the other important thing that I'd like to point out again is the HyperArc planning process is less dependent on users' expertise on SRS planning. So that's all I have for the planning side. I would like to thank my colleagues, Derek Liu, Andrew Alexandra, and Paul Blazinski for the help with this work. And thanks again for the opportunity to present my work.
Thank you very much. So questions, do we have any questions from the audiences? So we have a colleague from Shaukat Khanum, Dr. Khalid. He has a few questions.
How you can evaluate your SRVP plan, SRVP plan with respect to OAR? You can evaluate your plan OARs or PRV OARs. For example, spine SBRT or pituitary or some other that are very close organ.
Dr. Thakur, can you hear us? This was a question from you.
Well, I can hear you, but I couldn't understand the question.
So the question is,
how you can evaluate your plan with respect to OAR? You can evaluate your OAR.
Sorry, the voice is really low. Can you repeat the question, please?
So the question is that our colleague is asking, how do you evaluate your SRS SPRT plans in terms of OAR? Do you check the doses for the OARs or with other structures like OAR, PRVs, like for example, for spinal cord, for pituitary?
Yeah, we started with TG101 recommendations, and then now we are moving towards what HITECH has recommended. And then there are some other papers as well that we follow.
Dr. Thakur, we have some noise from your side.
Is it better now?
No.
Can you hear me better now? Seems like maybe there's some technical issue on my side then.
Yeah. Okay, so I have one question from Dr. Saiful Haq. So, Dr. Saif, you have spoken very comprehensively regarding this FMEA thing. Most of the international reports and certainly this TG100 speaks about the formation of a multidisciplinary team for FMEA. So, what are your comments and what are your recommendations to form a multidisciplinary team to conduct this FMEA thing?
Thank you for the question. It's just a very important question. The task group was very strong in their recommendations that you form a multidisciplinary task group because everybody brings the appropriate strength to the table. I'm a medical physicist. I don't know much what a therapist does, right? Similarly, a nurse, I don't know what a nurse does or vice versa. I don't know much about what the physicians are thinking about. So when you prospectively try to put a process map and the entire analysis together, you have the entire team. And I'll take a simple example. If you want to do, say, for example, a CT simulation for a 4D CT simulation, right? So you need to have a therapist, you need to have a physicist, you need to have a physician. They all are part of that process because everybody brings something to the table. And then everybody thinks prospectively as to what are the different steps that the patient will go through from the time patient walks into the CT simulator till the time the patient walks out. There are many steps involved. And everybody, the physicist has some contribution, therapists have some contribution, what the physician is thinking has some contribution. So as challenging as it may be, particularly when the physicians are very busy, it is very important to find a champion in the department who will really spearhead this process. Otherwise, if you miss somebody, an important component will be missing. Another example, why should an administrator be there, right? Well, if you do not have adequate staffing, that Thomas talked about it early on, the less effort is what the administrators want, right? But if you do not have adequate staffing and you have a long day, you are doing all this, scanning, for these patients, the therapist will be tired, right? The staff will be tired. And so that will lead to the errors potentially errors in the process. So administrator is important, IT people are important. So it's a multidisciplinary team that should be around the table for the generation, not only just the process map, FMEA, FDA, all of them. I hope that has answered your question.
Yes, thank you. That's perfectly. That's a good comment actually. So then I have another question specific to your presentation that you mentioned some of the strategies to overcome the issues regarding this 4D CT. So like one is to develop the protocols for the selection of patients, and secondly, the education of the patient. But for example, in a system like us, sometimes both of these things are very difficult to achieve. What are your recommendations or comments regarding the use of equipment? Because sometimes we do used to think acquiring some equipment for that, like for example, these new gadgets, visual coaching devices or other things. Will they help, or do they have?
So, absolutely. Another very important question. The technology, there are two comments I'll make. One is you can have all the technologies in the world, and if you do not have the right team with the right training, you will hurt the patient, right? So it's important to have the right people around the table. And I always say that, we have to learn how to use the technology correctly. You can have the best technology in the world, but if you do not use the technology correctly, then you'll be harming the patient also. So there are, you mentioned VCD and others. It is related to Varian technology. There are all these different gadgets that are there. VCD is something that you use when you are treating the patient with, say, breath hold technique, right? That helps the patient monitor, their breath as they take a deep inspiration and hold their breath. That certainly helps. And it's important if you are doing a deep inspiration breath hold technique, whether it is for a large motion tumor, or even if you're doing, say, left-sided breast treatment, for the separation of, the heart from the chest wall. So yes, the technology is important. You talk about VCD. Varian has actually, they had an RPM system historically, but they are now replacing those RPM systems with the VCD devices, as well as an RGSC, the scanner. The RPM system had a 2-block, 2-marker block and the camera at the foot of the table. Now that is replaced by a 4-marker block and another camera at the foot of the table. So that's an improvement of their technology. And VCD is used again for the patients to monitor their, the breathing pattern. So all of these are actually very important. They help you to really design the patient treatment, both in terms of safety and quality.
Right, thank you. I can see that Dr. Krohn has raised a hand.
Yes, thank you. I think this is indeed a very important question. And it is important to be aware of all the motion management techniques. A 4D CT is only one method of determining motion. We find actually that breath holding has become much more popular in our institution, both in exhale and inhale, as a means of trying to control motion. And we are really surprised how well patients can comply as soon as they understand what this is all about. So I think it is important to consider other techniques. PET scanning gives you the ITV as such. There are many different ways. And again, I think the multidisciplinary team needs to be presented with these options, which can be customized for each individual patient.
Agree with Thomas very much. Indeed, you should explore all the different possibilities, and whatever is best for your clinic, that's what you adopt. But it is important to know the strengths and weaknesses of all of them. Not a single technique is the best compared to the others. As I said, it's the team that makes the difference, not the technology. The technology is what we need to use wisely. Yeah, Thomas, we found in our clinic that, mostly lung patients, they have some problem because they are, breathing compromised. They have some problem holding the breath. So we usually treat our SBRT, the lung patients using free breathing, but we use a gated treatment. So you're very different in that sense.
Yes, there are so many different ways. What we do now, though, is we do actually send physicists to the simulation process in complex cases. So we get the clinicians to ask, to flag if there is a patient where there's complicated motion management things, and then the physicist is already there at the time of the imaging. And that indeed, I think, does help. And I think it is important to get the physicist early involved in these processes. But I agree. We also try to treat now patients in upright position, because for lung cancer patients, they find it much easier. And in upright position, you actually get that separation a breath hold does already just by sitting, and gravity pulling the diaphragm down. So there are lots of different ways how things can be done.
So you're using the Leo, the new, rock-matic upright position.
In-house development so far. I'd love to be able to buy the Leo CT scanner. That would be really cool.
If I may follow up with a comment from what Thomas mentioned, the physicist involvement is the team approach. It's critical, in every step of the process, because in SRS SBRT, we're treating with a very high dose. And it is our policy that the physicist is present at the simulation, physicist is present at every fraction when the treatment is delivered to evaluate the image matching. You know, the therapists, the physicists, the physicians, they all are present at the treatment and independently evaluate the image matching before the beam is turned on. So it's critical. I agree with you on that, to have physicist presence. I see Antonio has her hands up.
Yes,
Sorry, we are monopolizing the whole conversation.
No, it is not a matter of monopolizing. I wanted just to add a comment. For example, often in our practice, we forget about the simulation phase. And for example, the nice images you showed us, Saiful, in the 4D CT, a lot of errors are coming because of the irregular breathing. And let me say, the vendor is going to give you the visual coaching device, especially for the treatment, not by default on the CT. Why? So probably we should go in the direction of better understanding what happens and maybe adopt the technology with care, not just because the vendor is saying multidisciplinary and blah, blah, those things absolutely correct, because we have to understand what we have in order to properly use. And I would say additional visual coaching at the CT that is not so frequently used could be an improvement.
Yeah, we use that routinely at all our clinics. The visual coaching, both at the CT as well as at the machine. It helps the patient, and patient becomes familiar also with the technology. So that's a fairly regular thing in our clinic. The other comment, sorry, you made a comment earlier, and I forget now what you said. I wanted to say something about that. What was your earlier comment before the visual coaching? Oh, it's okay.
That was the multidisciplinary team FMEA thing.
No, but
no, not that. Antonio had a comment before the
I think
the visual coaching device.
I think it was about the importance of simulation and treatment, and I can really vouch for that. It's such an important point. We recently installed surface guidance on all our Linux, or the majority of the Linux, but that is not available in CT, which is really surprising. I think highlights the point you're making, Antonella, really nicely.
I know the comment you were making. So as you said correctly, pointed out that the patients breathe all different ways. They are not, robots, right? And so that's why the patient selection is important. And as Thomas mentioned, that they send a physicist, at the CT to make sure that the patient is breathing well. What we have done is, if patient comes in, lays on the table, patient starts to breathe. And if we observe that the patient is breathing irregularly, then technologists speak with the patient, and then we do a coaching. And the coaching that we use, instead of biphasic, like the variant provides a coaching, breathe in, breathe out. Instead of doing a biphasic, we do monophasic coaching, like breathe in and let the patient breathe out on his or her own, and then breathe in. And we do only audio coaching, and we do not use the video, because we found that patients start to hyperventilate. They start to anticipate, when the next coaching is coming, and trying to keep up with the video as well as audio, it becomes very challenging for them. And we have found that, for those patients whose breathing is irregular, the coaching helps. But in the end, you have to decide that a patient breathing is irregular. Those patients you obviously cannot treat with, IMRT or SBRT and all that. But we actually scan all patients so that even if we treat them with a 3D, we can generate a patient-specific margin, say lung patients, rather than putting a conventional 2 cm margin. we evaluate the motion and put a patient-specific margin for that.
All right. So we have two questions. First is Mr. Umer. Yes, please. There's a question for Dr. Thomas Krohn, right?
He showed us a plan of VMAT prostate, maybe it's the prostate plan, VMAT plan, and you use the FFF beams. So do you use interclinic in the normal plans, or you just use FFF beams in the SRSF SBRT plans? And is it recommended or helpful using FFF beams in normal VMAT plans?
I think that's a really good question, and we are trying to solve that for ourselves. At the moment, we use FFF beams in stereotactic treatments. However, we find it, for example, useful as we move in breast treatments to 5-fraction treatments only. They are in a, you can say this is stereotactic or it's not stereotactic. It is really sort of somewhere in between. It's a conventional treatment with conventional VMAT, but it's 5 fractions. It's only for breast. And we find an FFF beam can be useful in these treatments. But in general, we use not FFF beams in conventional fractionations with 2 gray perfection.
So we have a next question by Dr. Khalid.
I have a question with Dr. Saiful Hakim. As you are important member of AAPM, is there any upcoming currently a report that addresses all the FME issues regarding SRS, SBRT from simulation process to end of the treatment?
So very good question again. So AAPM, the TG100 report, it took us 13 years, by the way, to from formation to publication of that report. AAPM has a work group, and this work group has a web page on the AAPM website where we are collecting information from many different individuals. You know, you can submit if you come up with a good process map or a good analysis, you submit to the work group, and so we vet them, and our goal is to put them on the web page so that will help the users as a guidance. I want to caution you that please do not take any of the recommendations that anybody publishes as a guidance for your clinic. The Task Group 100 specifically mentions that you need to develop all the process map and the FME and everything that is specific to your clinic and your processes, because the way you treat SRS SBRT and I treat SRS SBRT, even though the concepts are similar, that the steps, there'll be many steps that are similar, but there'll be many steps that are very different. And that's why it's important that anything that you read in the literature or AAPM website or wherever, you use those as a guidance and develop your own. And to finally answer the question that you asked, no, there is no such thing as an SRS and SBRT specific that is published by AAPM and on a report. But there are many papers that different authors have published on how to deal with SRS and SBRT using the TG100 approach. Did I answer your questions? If not, I'll be happy to have a follow-up.
Yes, thank you very much. So, ladies and gentlemen, thank you very much. So it's almost the end of the session. I would like to thank Dr. Saif and Dr. Varun. It's something like probably midnight in the United States and Canada. And Dr. Thomas Krohn for the super evening, something like probably 6 p.m. and Dr. Antonella Fogliata for very early morning. Thank you very much once again, and thank you very much to the participants. So hopefully we'll see everyone sometimes in somewhere in next sessions. Thank you for the session. Thank you.
Thank you for inviting us. It was a fantastic session.
Thank you so much.
Thank you. Thank you. Bye.
Thank you. Bye-bye. Nice meeting you all, the speakers. Good seeing you all.